Thanks for that. Morning, Haseo. Josh, Anita. My Korean's very basic from years of Taekwondo, but I know a little bit at least. So welcome today. Thank you for hearing my talk and being present. So Warren spoke about a number of the tenets in our center. My emphasis tends to be a little bit more on the immunology side in terms of host response to different therapeutics. So our lab really operates at the nexus of drug delivery. After we identify next generation drug targets, we have interesting formulation techniques, which I'll show you shortly, but really at the nexus of the immune system. And so I have a twin brother. I've been interested in nature versus nurture for a very long time. And I sort of ran out of time in undergrad. I was working on calcium phosphate-based precursors for doing bone regeneration, and I didn't get to put one in an animal. I did like in vitro bioactivity, and I had so many unanswered questions about what happens in dense, very heterogeneous cellular microenvironments. And so for my PhD, got more into the cancer immunology aspects, which I'll talk about briefly, and then I'll show you some of the newer work we're doing. And that really got me to appreciate complex heterogeneous tissue responses, angiogenesis, blood vessel formation, and along with it, both the innate and the adaptive immune system. So if you care about drug formulation and delivery, historically, we try to, well, I don't believe there's a one size fits all. Some drugs make more sense to deliver in a pulsatile fashion. You want a heavier dose to hit something hard, maybe fall into a very specific threshold window. And so if you look at the peaks, it's not quite drawn to scale. Most bolus drugs we take, whether they're oral or IV administration, will usually start to disappear within 1 to 2 hours following dissemination. But we want to avoid those high peaks of toxicity that exceed the optimal threshold. And so phase 1 clinical trial usually was to determine what is that maximal safety. And interestingly, drugs that were known to be originally immunosuppressive, because at high doses they just kill everything, if you modulate them down just enough, you actually get anti-tumor immunity and positive immune modulation effects from them. In addition, other molecules such as receptor inhibitors and modulators, receptor tyrosine kinases, you may not want to deliver in a pulsatile fashion. You may just want them to have zero order release as a flat plateau and be ever present. All right, so again, phase 1 clinical trial, maximal MTD, maximal tolerated dose, going with all guns blazing. The problem is that because of the high toxicity, the animal needs to recover, the patient needs to recover over a long window. And in the context of cancer, typically the tumor would actually not only regrow, but exceed the original volume when you started treatment to begin with. Conversely, there was a concept that came out of Judah Folkman's lab at Boston Children's Hospital many years ago. And this concept is called metronomic chemotherapy. So if you play an instrument, metronome keeps even time. If you play violin, piano, whatever. And you could do daily through the drinking water on the right-hand side here, continuous low dose. But we actually found that dose thresholding was very important because as a consequence of, a little bit of a dose, the stress induced by that smaller dose would be reversible. High enough of a dose, you'd fall into a range where it wouldn't destroy the immune system, but it would damage the tumor to give off immunogenic cell death signals for the immune system to come in and clear out that damaged tissue as though you had been punched in the arm. And we found out that this was, originally they published this phenomena. So CTX on the bottom left is cyclophosphamide, and this drug is, again, thought to be immunosuppressive. It's even used for lymphodepletion prior to adoptive cell transfer, but you can see there's actually originally a spike in apoptosis or cell death in the endothelium shortly thereafter in the tumor bulk because you're choking off the tumor. Well, this was actually a reproducible phenomena. They tested every 3 days, every 4 days, all the way up to every 12 days, and they found approximately every 6 days was optimal, just like a predator-prey relationship, to maintain this ever-present secondary mechanism of action. So the drug was cytotoxic, but now it's also anti-angiogenic by just changing the way that you give it. All right, so an early graduate student, my PhD lab, Jima, he said, well, what happens if I combine this with a true VEGF receptor 1, 2, and 3 blocking agent, axitinib? We were doing a collaboration with Pfizer at the time. And interestingly, in this rat 9 glioblastoma brain cancer model grown in skid mice, so we didn't even think to look at the immune system because it stands for severe combined immunodeficient. So why is it, there's no immune system clearly, right? But you have to minimally knock out T and B cells or T cells alone to grow human tumors or tumors from a different species in a mouse. Otherwise, they get rejected. In this particular context, you can see that every 6-day cyclophosphamide, we're calling it CPA here, all of a sudden, about the 3rd or 4th injection, the tumors stopped dead in their tracks and they turned around and they started regressing dramatically. And so the original hypothesis was this was due to the additional anti-angiogenic effect. The problem with a lot of small molecular inhibitors is that the signaling blockade and embargo on a cancer cell eventually gets rescued by other kinases in the cell. And you can see that while there was initial stasis with daily administration, daily injections we were doing in mice, the tumors eventually escaped axitinib treatment, and they grew with a slight delay over time. So G combined the two, and initially it looked more effective. The tumors were stopped dead in their tracks, but the problem is on the very back end, this more extreme regression that would eventually cause the tumors to disappear was ablated. It was damaged and destroyed, and we were not seeing that. And so here are the skid mice in the middle. You can see that they lack T and B cells at the top. It's basically the boy in the bubble disease. It is a mutation that exists in human, but they had their entire innate immune system left intact. So there's been some talks about viruses today. I had my early work in synthetic biology, working on oncolytic cancer selective viral vectors to spread through and kill cancer cells, but not affect healthy tissues. And even in the skid mice, those two disappeared because of the active sentries of the innate immune system. We also then got questions, they're missing Tregs, they're missing other regulatory cell types. How do you know that this regression you're seeing isn't an artifact and that it might be seen in patients? So it took this response in two different directions. One was to test in Nodsky gamma mice, which additionally lacked NK cells and also had macrophage and dendritic cell dysfunction. So if they're necessary and required for regression, if you damage them, you no longer see regression in theory. And on the far end, a fully immune competent, we found a syngeneic brain cancer line from the Black 6 strain to use in testing the full immune system. So firstly, in skid mice, what you see with metronomic chemotherapy is dramatic increases in CD68, net macrophage marker, NK1.1 for natural killer cells, and dendritic cell markers too. This combination therapy, where we saw damage regression on the back end, ablated immune response across the board. And there are many reasons for this. I don't have time to get into all of them, but one of the examples that came up was this balance is rudimentary. I don't even like to say M1 or M2 anymore. It's oversimplified immunology, but this drug, so metronomic chemotherapy, if you compare the ratio of pro-tumorigenic macrophages in the numerator via arginase 1 expression to anti-tumor in the denominator with NOS2 expression, the balance really was not shifting with metronomic chemotherapy alone over multiple rounds of treatment. It was really due to that VEGF receptor 1, 2, and 3 blockade over more and more time. So 12 days later, 18 days later, both alone and in combination with the chemotherapy, that we saw skew towards pro-tumorigenic behavior. Did originally a microarray study. I know that we're doing bulk, single cell, and spatial omics now too, but originally got into pathway generation, even identifying with engineering pathway analysis, signaling cascades going from extracellular through the transmembrane space, molecules all the way down to affect signaling activation in the nucleus. All right, so and then the full immune competent, so first NSGs, so this is what the regression looks like in the skids. And then with the NSG additional depletion of the innate immune system, you no longer see regression, you just see delay. Black 6 model, not only was there regression, thankfully, otherwise this probably wouldn't have been published in Cancer Research, but you can see regression in red happened even faster. We were actually recruiting in CD8 killer T cells in addition to the innate immune system. Metronomic chemotherapy later was shown to even prune away and get rid of Tregs and myeloid-derived suppressor cells. I co-delivered an anti-GM1 depletion antibody. It binds natural killer cells with like an antibody raised in a rat, makes those mouse NKs look like they're rat cells, and the rest of the immune system clears them. And you can see in blue, the regression was delayed, and it was also incomplete until around day 42 or 45, stopped giving the depleting antibody, but maintained chemotherapy. And then as those NK cells rebounded, the regression became complete again. The purple trend is a single knockout for perforin. It allows for granzyme flooding used by both innate natural killer cells and adaptive CD8 T cells, and you can see that it damaged it even further. And these were subcutaneous xenografts, which actually then invaded into the abdomen and all throughout the mouse. That's why those error bars started to grow dramatically. I was nervous at first when it was regressing this way, but it wasn't pretty. So this mechanism really showing host response, breaking down engagement, punching the tumor, if you will, every week, every 6 days, recruiting in cells to clear regression. Even got into, this is an interesting case, this antibody. So if you know bevacizumab or Avastin, the problem with Avastin in usage in mice is that it only binds human VEGF. And so in mouse preclinical trials, they didn't see side effects with host response. And eventually it was even rescinded for use in breast cancer because they saw neutropenia, impaired wound healing, other major problems. And I identified this VEGF receptor 2 targeted monoclonal antibody from ImClone, which coincidentally was the company that Martha Stewart went to jail for short selling her stock on. I thought that was a weird small world moment. But in general, you can see yet again in the purple trend, combining it with the VEGF receptor 2 targeted antibody also impaired regression on the back end. It looks very similar to G's earlier work. And if you change the compound away from axitinib, which is very targeted to VEGFs 1, 2, and 3, the IC50 selectivity of axitinib was 250 or even over 1,000-fold higher than sorafenib, which is not really selective for the VEGF receptor axis. It's a much more multi-pan receptor tyrosine kinase inhibitor, and it actually led to anti-angiogenic effect while leaving the anti-tumor immunity intact, and you see regression in both cases all the way to the right. And so, but VEGF receptor 2 became apparent through me looking through the literature that it was important for immune homeostasis. Progenitors of endothelial progenitor cells and immune progenitor cells do eventually merge back into the bone marrow. VEGF receptor 2 is preserved on all of them. So just be mindful of those types of drug combinations. In terms of the small molecules, it's obviously very arduous to have to inject them every single day, right? So we don't want to do that. And really, you're not hitting flat plateau release. You have basically pulsatile presence, a whole suboptimal tail where you can breed drug resistance when the drug's being cleared. So there's other therapy formulations that we take into account. This is actually a solvent-into-solvent drug crystallization scheme. This is also sorafenib. And you can see, just like carbons in a tetrahedral address of a diamond and diamond ring, you see a monomer stacked after monomer of sorafenib over and over again in a very dense crystalline form. And you can tune its surface area to volume ratios to change kinetic rates of release. We even have this cool video here where there's a bulk erosion where we have DMSO speckled throughout the top form, and it's so hydrophobic, you see the crystals reforming on the outside edge. It's losing density, but then they reform. It's called autocrystallization, whereas the bottom form, which diminishes very slowly through redissolution via surface erosion release, can last for days to weeks, if not months. And we even had, so there's stability testing you do. You can see that smaller crystals in red release faster than the larger ones in blue, shown photographically as well. Had anti-tumor efficacy, even showing it's sort of like you're shooting from the hip. It's not really milligram per kilogram dosing, so you have to sort of tighter up the milligram amount that you deliver. And we finally got milligram amounts that were close from a single injection at day 0, by the way, just one injection of about 4.5 milligrams was able to maintain the same amount of anti-tumor efficacy as doing 4.5 milligrams per day for 10 days straight. So 45 milligrams as opposed to just 4.5. And then furthermore, because this drug is so hydrophobic, I jokingly call this class of receptor tyrosine kinase inhibitors pharmacologist's worst nightmare, because to dissolve them, you usually have to use anywhere from about 1/3 up to 2/3 by volume fraction of DMSO. Very, very powerful organic solvent, which will also dissolve tissues. And so the daily dosing of that, you can see the mouse body weight loss in blue, whereas the crystalline forms that we could just shunt in with saline or PBS, you don't see any of that. You spare toxicity across the board. All right, another quick example in context here is with transplantation for type 1 diabetes, and where you talk about encapsulation, trying to prevent them from being touched and flooded with granzyme by the immune system. And so instead, the body turns its attention to the encapsulating biomaterials. That wall, it's a pretty image, but that wall of immune cells is the worst case scenario, because they, in and of themselves, have their own respiratory and oxygen demands, and they basically outcompete the graft inside. There's a dead zone and the graft dies. And something I also learned too from my PhD, comparing non-SCID gamma to SCID to Black 6, they're technically different genetic background strains of mice. It's not a clean comparison. And thankfully, Black 6 mice were the profibrotic model for foreign body response. And there are individual point mutations and single mutations all within the same background strain to remove T cells, B cells alone, both combinatorially all the way down to the level of the innate immune system. And so what this looks like is you can see the wild type response of overgrowth from being in the abdomen for just 2 weeks in these Black 6 mice in the top image. The bottom image is with macrophage depletion. So macrophages are the arbiters of foreign body response. In the middle, neutrophils were depleted. If anything, they became more aggressively clumped because you're losing myeloid-derived suppressor cells, negative feedback on the immune system. And so this work, we eventually then took these drugs and put what this antifibrotic identified from a pathway hit. We crystallized it and co-encapsulated it into capsules along with islets, and it was so targeted to the monocyte macrophage axis that it was not deleterious at all to the multicellular cluster of islets. You can see them very happily in green, standing live rather than dead. We had drug release over 1.3 years in this context, with crystals remaining at the end. By comparison, if you tried depleting macrophages, I did that weekly with clodrazole out to about 60 days, but then eventually mice lost body weight and started dying from the toxicity of it. You don't see that here at all. You actually see that the drug has opacity. It depends on the color. You can have drugs that are blue or green or orange even, and you'll see that color in the crystalline form. The PK/PD data on the right shows millions of nanograms in the capsules on the right-hand side. IP space has a lot more liquid turnover and faster redissolution. And you see the drop-off from the drug from 1 month to 3 months to 6 months in purple. Subcutaneously, which is known to be a diffusion-limited site, you see a much slower redissolution and release over 3 and 6 months in the blue trend. And then conversely, because this drug is being released it's the tuning of the release is so controlled, that when a little bit of drug leaches away, it dilutes into the much larger circulatory blood volume of the body. And so when you look in the plasma, in circulation in the blood, nanograms per mil, you're at only maybe tens, if maybe slightly over 100. And there's a small impure fraction of powder or small crystals that releases very quickly. And within about a week or two, systemic drug levels are at or below IC50. You could make a very strong, compelling case that you will not have off-target effects elsewhere in the body, which is very much unlike having IV infusions or taking oral pill forms. All right, so this is an example of this antifibrotic technology. This is minimally invasive laparoscopic surgery in a non-human primate, cynomolgus monkey. We sprinkle these biomaterials along the omentum, which is a tissue wrap around the GI tract all the way down to the Douglas space at the bottom of the abdomen. The lobes of the liver are up towards us. And so you have one port for the camera, one port you spray in saline. And if I play that again real quickly, you can very quickly, you see the capsules at the bottom already, and the saline will basically wash these capsules right off the omentum, whereas opposed to having no antifibrotic, they get stuck and embedded and completely remodel this soft connective tissue into very dense, high tension scar tissue, fibrotic tissue. All right, so we've also been able to encapsulate this into PDMS, so we can put actually within the bulk material, we can even do cured on coatings on different devices such as continuous glucose monitors. You see without the drug in control, the host response is so strong it popped the sensor out of the polymeric housing. That's how much force these cells eventually in time will apply. With different crystallized drugs, you can see all the way to the right, we diminish that back to the levels of just connective fascia. You can see how opaque it is. You don't even see the implant at 4 weeks under the skin when you flip the skin over, but with the drug, you see complete translucency and no opacity at all. This was a muscle stimulatory device in the bottom, same issue, white overgrowth, fibrotic capsule with drug on board, reduction, and we were able to then stimulate the hind limb atrophy model to stave off and to prevent muscle atrophy in this context. So last slide, just briefly. So realistically, we're collaborating with Warren's team. I didn't have time to talk about the light chain microscopy we're doing with them with metallic systems. We've had funding from the FDA. Over the years, I've looked at not just hydrogels, but different polymers, natural and synthetic. Metallic systems we have a spatial ICP-MS core here where we can actually see release of metal ion debris and corrosion and pitting and trying to discern, and the FDA was interested, is it just the implant or is it some other releasing field that's going on too? But effectively, we can sort of agnostically take a drug or biomaterial device system, put it in the body, characterize it even with whole body IVUS imaging for inflammation, placing it into the therapeutic site of interest to look at host response. Done this in monkeys, done this in rabbits, done this in pigs, and we've also more recently published on a humanized model, which we've irradiated and transferred in a human immune system into a mouse as well. So just to thank the team and for you guys for listening, very much appreciate it. Happy to take any questions. Thank you.